It's a slow Monday morning shift in the ER when EMS brings you a 42-year-old male brought in after collapsing while working outside. Initially, you get 2 large bore IVs on the patient and get him hooked up to the monitor, and you see that his heart rate is 48, his blood pressure is 88/52, and his respiratory rate is 30. He's satting 90% on room air, and his temperature is 37.1 degrees Celsius. EMS also got a glucose for you, which is 112. When you walk in the room, you see a diaphoretic, drooling male who is incontinent of his urine, and he's gasping for air. Immediately, you suspect an airway issue for this man, so you prepare to suction and even intubate early because of how many secretions he's putting out. EMS also tells you that there was a garlicky smell and to worry about exposure. So you decontaminate the patient by removing all of the clothing, putting it in double bags, and then doing copious soap and water irrigation while you're protected with your PPE. So resuscitation wise, you want him on the monitor and then you hang some fluids for the low pressure. And you try and get some further history from EMS. So it sounds like he collapsed 15 minutes after spraying something in the field. It had a garlicky sulfur-like odor, and the patient had progressive dyspnea, vomiting, and excessive sweating, says his coworkers. He has no prior medical history and he does not take any home medications. So you progress to the physical exam and you see a confused patient with some fasciculations and muscle weakness. When you examine his eyes, you see meiosis and tearing. You listen to his lungs and you hear diffuse crackles and copious secretions. And then on your GI exam, you've got profuse diarrhea and emesis. On your skin exam, you see a diaphoretic, very moist patient. So you go ahead and get some labs from your IV. So you draw a CBC, a CMP, VBG. You also call for a chest x-ray and then you get an EKG for this bradycardia. And then you also draw a type and screen just in case he's bleeding, but you're not super suspicious of this. Respiratory brings back that VBG and it looks like he has a respiratory acidosis, some secretions and bronchospasms. And then you get your x-ray back and it looks like he might have a little aspiration pneumonitis there. Otherwise, your labs are overall insignificant. So what's going on? Most likely this is organophosphate poisoning, and organophosphates irreversibly inhibit acetylcholinesterase, leading to excess acetylcholine at muscarinic, nicotinic, and CNS receptors. So you treat these patients clinically, not by labs. A lot of people like to remember these patients by wet and weak. The classic clinical picture is remembered with the dumbbells mnemonic for muscarinic findings: diarrhea, urination, meiosis, and you have your killer bees, so your bronchorrhea, your bronchospasm, and your bradycardia, emesis, lacrimation, salivation, sweating, and then for your nicotinic signs, you'll see fasciculations, muscle weakness, and even paralysis. For your central nervous system findings, you might have a confused patient, you might see seizures, or even a coma. So how do we keep taking care of this patient? You want to start atropine. Atropine blocks the ACH at the muscarinic synapses. You want to do large doses, escalating the IV doses. So you can start at 1 to 3 milligrams IV every 5 to 10 minutes until the bronchorrhea and bronchospasm resolve. There is no ceiling dose here, and a lot of times you're going to be blowing out the stock. The ophthalmologists with those atropine drops are really where your gold mine is. Those little vials have a bunch. So reach out to Ophtho or get pharmacy to send those ophthalmic drops down. Your next intervention is going to be pralidoxine, and this is 2-PAM, and you can remember 2 grams of 2-PAM. So it's 2 grams IV over 15 to 30 minutes, and you can repeat this every hour or start a continuous infusion. You want to give this early, within 1 hour ideally. So 2-PAM binds to the organophosphate acetylcholinesterase complex, and it cleaves the phosphate group off the acetylcholinesterase.